Tell us why it's so significant.
Well, a lot of women can't or prefer not to use hormone replacement therapy. And so Linkwit, the generic is Elinzanetant. This adds another option for women that's not hormonal.
I find it interesting when we see things like that where they say women who either can't or don't want to take hormone therapy. Most of the women that I see who don't want to take hormone therapy are doing it because they are not well informed. And even when they are well informed, some of them still have that fear where they prefer not to, and that's okay. It's always your choice. However, most of the women that I see who get in contact with me for a courtesy call that want to discuss and they say, I don't want hormone therapy, I can ask why. And it always comes down to they have not been informed. And you cannot give consent without being informed, which is why we have informed consent. So these women are coming to us saying, I don't want to do hormone therapy because they don't understand what that means for them in the future. I haven't met a woman yet who couldn't have some form of hormone therapy, whether it was, just testosterone or progesterone. We have so many different options and so many ways to administer hormone therapy. These things are very important to note. Also, it's not about I can't have hormone therapy because most of them can. Sometimes it's about a provider not being willing to. At the end of the day, what do the studies show? So now we have a pharmaceutical coming out in, I believe, November of this year that is not hormone replacement that women are going to be given and pushed by their ill-informed doctors, their under-trained prescribers, as an alternative to hormone therapy. As you can see here in her video, she's already pushing it as an alternative. It is not, to be clear, it is not an alternative to hormone therapy. It is an additional Band-Aid solution to mask vasomotor symptoms. You could do that with an herbal remedy if you wanted to, and there probably wouldn't be the same side effects.
To control hot flashes and other symptoms of menopause. We've seen phase 3 randomized clinical trials now showing good evidence for this, and the FDA has now approved this medication.
Yeah. Side effects, downside?
Well, there are some side effects. So fatigue, headache, for example. They have checked liver toxicity out to a year. We're not seeing any signal there, but that will need to continue to be monitored because we don't have data beyond a year.
So why don't we use the data that we have already instead of saying, hey, here's something that's new, that's only been studied for a year. We don't know any long-term effects of this. It could very well turn out to be very bad for some of us. When we have lots of data showing the safety and efficacy of oral estradiol, we're focusing on estrogen, but we're forgetting the estradiol. I mean, I say we are not forgetting the estradiol because we know we have evidence of how well estradiol works and how safe it is. It has a fantastic safety profile. You can use this, not just for vasomotor symptoms, but for all of the other things I've talked about in a million different videos. Why are we developing a pharmaceutical, another pill for your ill? Why are we developing yet another pharmaceutical remedy to fix something that we already have an existing fix for? There are not women out there who can't take hormone therapy. There are women out there who need to have their hormone therapy customized. This is precision medicine. Why don't we start teaching people how to treat patients in perimenopause and menopause and oncology, hormone therapy? They go together, breast cancer patients. Why are we not teaching this? We need to stop separating the body into different components where none of these specialists talk. Your oncologist doesn't have hormone training. Your gynecologist might have a couple of hours of hormone training, and else they decided to specialize. Your family doctor, who you're going to go to first, doesn't have any hormone training. Your cardiologist doesn't have hormone training. Why are we not teaching these specialists the hormone component to what they do instead of giving out yet another pharmaceutical drug? Hey, question for you. What was the funding that went into the development of this pharmaceutical? What if we had taken all of that money, because it's not cheap, and put that into adding on to the already existing data that we had in regard to hormone therapy during breast cancer after breast cancer remission at the 3-year mark, breast cancer remission at the 5-year mark. Why are we not using this data that we have from some pretty impressive, robust studies? Instead, we decided, specifically for moderate vasomotor symptoms, to give another Band-Aid solution that's no better than an antidepressant or an anti-anxiety medication instead of hormones, pretending that some women simply can't or won't take hormone therapy.
But so far, it looks very safe.
So when will it be available, Celine? And then how much will it cost?
Well, we're being told available next month, November.
Next month. Wow.
And the cash price is $625 for a 30-day supply. But for many women with insurance, the monthly cost may be as low as $25 a month.
Why do you think it's taken so long to get something like this on the market? So many women, myself included, were so afraid back in the day.
I can tell you why. Because up until about 1993, women and minorities weren't included in the studies because we didn't matter. I can also tell you that until the early 2000s, women didn't have safety data on medications until it was demanded. Things were put into law that, hey, we need safety data for women. They matter because we're not just tiny men. So now women and medication are being studied. I mean, it might also have something to do with the fact that women are allowed to own property, have credit cards in our own name, have vehicles, vote, have jobs outside the home, make our own money. And many of us are doing very well for ourselves, which means we now matter because we can spend our money on their product. So let's give a shit about women because we want their money.
Think about it. If you're a researcher, a scientist, a doctor, you're going to study the things that you have maybe personal experience with that matter to you. You had a family member who had this issue. And so depending on who is doing the research, you're going to see a certain bias in what issues they decide to study.
Actually, what you're going to see is they're going to study what they can get funding for. Hey, I'm going to give you lots and lots of money if you study this topic. Here's your money. Study it. But make sure you find what we want you to find. I don't care if you come for me saying I'm a conspiracy theorist. A fact is a fact. You're not going to disappoint the people that funded your study. So you want to make sure that the data you're presenting lines up with the people that have paid the bills.
As we've seen more women go into medicine, of course, they're more excited about studying the things that are going to affect them.
There's a bit of a body shift there because she knows what she's saying. Basically, more women in medicine, more women in the sciences, more women allowed to have positions, to hold positions of importance in these particular areas means that more women are out there pushing. Also, we know that we have more studies now because we've demanded it because of all the social media out there, all these different platforms where women got really loud during the pandemic. Nobody was talking about menopause. I mean, we were hush-hush tones. Nobody was talking about hormone therapy. I mean, we were, but we were labeled, charlatans and quacks and pseudoscience, which turned out that it was actual science. Shocker there, not for us. We were labeled. And then women got loud about it. They demanded better care. And then the NAMS rebranded as the Menopause Society to trick all of you into thinking they were somehow some sort of a fabulous certification without any training. That's kind of BS. I'll die on that hill. I will. We've been duped. Ladies, we have treatment for menopause. We have literature, we have data, we have randomized controlled trials, we have meta-analysis. We've got other countries. We've got Canada, US, we got Europe. Listen, we got studies for the studies for the studies that show the safety profile and the efficacy of specific hormones based on how we administer them. What's the problem? The problem is that big pharma said, here's what we've got. Here's your progesterone in 100 milligrams or 200 milligrams. You can't even get the 200 milligram in Canada. It's got to be take 2 of them or compound it. I can tell you, I have used the compounded. I have used the pharmaceutical. I've used all the bioidenticals and the body identicals. And I see firsthand with my patients what does what works the best, what has better efficacy. You don't have to do compounded. Does it work better? I find for most of my patients, yes. But if you're not used to a compounded, you're not going to know the difference. You're still going to get a result. And if you run into problems, then we compound. At the end of the day, we know progesterone is so protective for your breasts against breast cancer. Why are we afraid to administer it when someone has active breast cancer? Because they might have a progesterone receptor positive breast cancer? That's not how this works. Why don't we talk about it? We have the data, we have the literature, we know. Why are we still out here doing a disservice to women? Why don't we study the things that matter instead of continually saying, let's slap a band-aid on it, only study it for a year. And then when you develop the side effects that we didn't realize were going to happen, because they will, mark my words, then we're going to slap another band-aid on that. That's what we're doing for hot flashes. That's what we're doing for night sweats. But we're not protecting my bones or my brain or my heart. That's kind of a big deal. We're more afraid of breast cancer than we are of dying of a heart attack. Let's talk about the safety profile of hormones, how they protect you against cardiovascular disease when done right versus without hormones, what's going to happen. And I feel for these women who have active breast cancer or a history of breast cancer who can't find a provider to prescribe hormones that are not only going to be safe, but also effective. They're going to improve their outcomes with hormone therapy. Again, hormone therapy could be anything from testosterone, estradiol, progesterone, DHEA, hormones, big umbrella. That doesn't mean all of the hormones are going to work for everyone. Maybe you can only do a little bit of this administered in this particular way, but the other one isn't going to work for you. You deserve to know what your options are, all of the options, not only what a pharmaceutical company can offer you, but hey, what about a progesterone troche? Maybe that's going to help with some daytime symptoms. Maybe you're progesterone sensitive, so that's a better option than the traditional nighttime make you sleepy, dozy, drowsy version that we're all given, the Prometrium, even the compounded. We're worth more than what we're getting from medicine. Women deserve to have choices. The choices are out there. We deserve to be educated on the choices. So this Elinzanetant, this new medication, targets the hypothalamus regulatory center. Basically, it blocks NK1 and NK3 receptors. These are the guys that when estradiol drops, they basically cause all sorts of hot flashes and temperature dysregulation. So hot flashes, night sweats, all the good stuff. In perimenopause, going into menopause, we know that our estradiol drops and it fluctuates. It goes kind of crazy. Well, these neurons also go haywire. So by antagonizing NK1, NK3, essentially what it's doing is dampening that effect. So that's going to be great for those of you who want it. I mean, I wouldn't, and I won't be recommending it to anyone in my practice. That being said, it is going to be marketed as an alternative to hormone therapy. And I want people to understand, I want this to be very clear. It is not an alternative to hormone therapy because it is not hormone therapy. It is not a more natural solution. I mean, hormones are natural, so I don't know what that's about anyway, but it is not an alternative. I say it's not an alternative because an alternative to hormone therapy would be something that does what the hormones do, meaning all of that age-related disease prevention that we get from hormones. This isn't going to do that. And since it's not going to do that, it's not going to be a hormone equivalent. It's not going to be a replacement for proper hormone replacement therapy. Basically, it's going to treat one symptom cluster. But I mean, there's herbal remedies out there that will treat those same symptoms. I feel as though this medication is going to create more chaos and do a disservice to many women in this space who don't understand what's actually going on. So for women who truly, for whatever reason, decide they don't want to do hormone therapy, just be aware that this isn't the alternative that you think it is. We only have 12 months of safety data on it. It's not a very long time. This is set to be released in November of this year, 2025. If you were offered this, and I'm fairly certain that every woman out there is going to be offered this from her family doctor as an alternative, because again, they don't know what else to do. I can see this becoming very popular very quickly and going south just as fast.